nursing documentation with regards to residents with change of condition, and we have some issues that we need to tighten up. And we'll just go through with some of the regulations, a short review of the regulations, and review the findings, and make sure that we are really, this would allow you to change and do some changes with your documentation, okay? So what is the use of our documentation? Why are we making medical documentation? What's the use? Why do we need to do medical documentation?
Payment.
Payment, that's primarily. Okay, aside from payment.
To update regarding residence conditions.
Yeah, it's used for your plan of care.
Yeah.
Okay, it's also used for legal purposes. When they
Yeah.
go to legal, that's where they use. It's also used for your federal and state compliance. When you have your surveys, they look into your documentation, and that's where they use it for your deficiencies. Okay, so just a background. Since 2002, Medicare had started penalizing hospitals for residents being readmitted within 30 days. CMS is also penalizing nursing homes now because of patients getting readmitted to the hospital within 30 days. Your documentation also feeds your MDS. You know MDS is being used for your reimbursement. So if you have poor documentation, your MDS won't be coded accurately, and that brings down your reimbursement. So documentation really ties up everything. It also affects your quality measures. It affects your 5-star rating. The 5-star rating addresses your UTIs, your pressure ulcers, residents on pain, and that's taken from your documentation. So those with 1-star rating, 4-star rating, affects, it's a reflection of their documentation and the care they provided. So if you have good documentation, you get good ratings and quality measures. Okay. So why do we need to document? We need to document to make sure that the team would know what is expected with the resident and what's going on with the resident. That's why we need to document those things. We need to enhance our practice, making sure we're telling a story with the resident. And there should be a closing of the loop. If there's a problem, there should be a resolution. We're not just addressing the problem, but we have to resolve the problems. Your clinical documentation should tell you, okay, resident has a UTI, what happened to the UTI? Did it get resolved? Did the wound get resolved? Okay. Was there a change in ADL? What did we do with the ADL? If he went to therapy, what's the effect of therapy? So that has to show up in your documentation. It's being used by your physicians. The physicians are not here most of the time. They rely on the nurses. Nurses are here 24/7. So we have to make sure that what we're writing, because the physician will look into your documentation. If it's not written, it never happened. So it's hard for the physician to plan medical management of residents if nothing is written in the notes. And it's easy for the physician, it was not written in the nursing notes, so I don't have any basis. You're not always there when the physician comes. These different nurses are coming, taking care of the residents. So we have to make sure all those information, what happened in your shift, is reflected in the clinical records. Okay. The importance of documentation with change of condition is that we need to report. The sooner we identify a change of condition, the sooner we implement interventions, and the better is the outcome of the resident. Okay, so we are the eyes, ears, and hands of the care team, and a standard of care is like an RN assessment. I know LPNs cannot do an assessment. LPNs, you do observe things, so you have to write your observation, and you're not doing assessment, you're observing and writing what you observe with the patient. Okay, so if you observe something, you have to refer it to the nurse who will do the assessment, or your supervisor. Because the supervisor has to write things. So how do we detect change? How do we know that there's a change in a resident? What are the things that we need to identify? How do you know that something is happening to your resident?
Poor appetite.
Poor appetite. Behavior. What else? The change in vital signs. Yeah, basically vital. And knowing what's the baseline of a resident. If there's a deviation from the baseline, then you would know that something's going on with the resident. So you know what's the routines of your resident. How do they do with the ADL? What's their mobility status? So those are the things, and you identify this through constant conversation with your resident, and not only with your resident, with the family of the resident. If you know these are the things that they're doing at home, and these are the expectations, especially for your long-term residents. You should know what's the baseline. And even with your short-term, you need to know the earlier, the better you take care of your residents. So these are just a couple of the 12 changes that happen in your residence. It's in your handouts: walking, urination, skin. Those are physical changes, and we have also non-physical changes, which includes your demeanor, appetite, sleeping. Just a couple of things that you need to be aware of. Okay. What are the two tools that we're using to identify change of condition?
Stop and watch.
Stop and watch,
S-bar.
S-bars. Who's responsible for writing stop and watch?
CNS.
Everybody,
Yeah.
not only CNAs. So your PT, OT, dietary should be able to write things that they observe. Okay. The S-bar, who's writing S-bars?
Nurses.
Nurses, LPNs, RNs. S-bar is not an assessment. S-bar is a tool. Okay, it's a tool that you use to write things that you observe. If you're an LPN, to your resident that needs to be informed to your physician. It helps you it guides you what are the things that you need to tell your physician if something's going on with your resident and what interventions you did. So it has to be done before you call the physician. That's the purpose of the S-bar. And it's not only used when you transfer somebody out, it's used for any change of condition. So if you're like, oh, I'm LPN, I'm not writing the S-bar because it needs an assessment. No. It includes observations you identify with your resident. It doesn't limit to assessment. Okay? So S-bars, your LPNs, RNs are supposed to write those things. So this is just a workflow of the S-bars. So, and the stop and watch. So CNA identifies a change, completes the stop and watch, tells the nurse or the LPN goes and sees the resident and identify what the changes are, completes an S-bar and calls the physician. Okay, you know the process. Okay, also just a couple general documentation, assessment or observation, you collect the data, action or your interventions, the response of the resident, and evaluation whether your interventions are effective or not. These are just a slide that will tell you what are the things you need to write with your documentation. So it's addressing the 4 W's: who, what, why, when, and how to document things. So in your resident, if you're there in 24 report, why are they in the 24 report? What are you writing? Why are they written in the 24 report? What interventions did you do with that during your shift? And what's the outcome of the resident? If the resident is antibiotic, why is he the resident of the antibiotic? What's the outcome? What's the response of the residents with the antibiotic? That has to be in your clinical record. Not just antibiotic in progress, no adverse reaction. It has to be more specific. Okay? So just do's and don'ts on documentation. Make sure it's chronological. It indicates the time, date, signature with your credentials. Avoid using normal appears. Do not chart in advance. Most important, do not use texting language. There's a lot of, because of technology, we're utilizing what we're texting and putting it in a clinical record. Also, and inappropriate abbreviations. Make sure you're not using, it has to be a standard abbreviations. Okay? I saw some documentation in SE resident. What's SE? Sin and examine, they use SE. They're making shortcuts of things, so which is not a standardized abbreviation. Also, make sure it's facts. Don't assume things. When you're doing teaching and health training, make sure you're documenting what's the response or how did the resident or family understand your teaching. That's important thing. Do not document like continue plan of care. What plan of care you're continuing? Okay. Remain stable. Tolerated well. Okay. Be precise. Just a couple of things. Be specific. Okay. Do not, as I mentioned, do not assume that resident fell while ambulating in the bathroom versus resident observed on the floor near the toilet. Just document what you observe. Don't assume things that, oh, this resident rolled out of bed because she was found next to the bed. When you come in, that's where you see the resident, just document those things. Don't make assumptions. Things that you did not observe. Okay, and be aware of what. You have to make sure those things. no behaviors noted. What behaviors are you monitoring? Be specific on behaviors. Okay, those things. Just a couple of things that we identify during this is just some examples. Okay, during my visit, in your dashboard, you would see the stop and watch interact section. There's a couple of stop and watch not being addressed. The CNAs are documenting the stop and watch. You have to make sure that you're constantly checking those dashboards, because if there's something there, it has to be addressed. So that's that's an easy gotcha that these two stop and watch were not addressed, addressing a change in walking, transferring, and toileting, and a change in skin condition. But I don't see any nurses note that the nurse checked on this resident. And then if something would happen, it will be a problem because there's no follow-up on those things. So always check your dashboard in Sigma for any stop and watch that's completed by your CNAs. Okay. Another thing is a progress note written by a licensed nurse about an antibiotic. Okay. It shows signs and symptoms of productive cough, congestion. Resident noted with cough and greenish secretion, MD made aware and ordered to start Rocephin 1 gram IM for 7 days. Family at bedside and aware, encourage PO fluids. The problem here is that when I was reviewing the chart, the nurse's signature doesn't indicate whether it's an LPN or RN. Because so you won't know whether an assessment or an observation was done. You have to make sure that there's an LPN or title after your signature, so that you would know that if an LPN, it's an observation, and I need to tell my supervisor about this. If it's an RN, then there should be a full assessment, like auscultation of the lungs, what's going on. Okay. Another thing with this progress note, I did not see any documentation as to what's going on with this resident prior to the shift. Suddenly you start an antibiotic on this shift. Was this resident observed coughing in the previous shift? Nothing. All the documentation of the resident was stable, she's fine. Then suddenly on this shift, you have this greenish phlegm and started an antibiotic. It has to what's going on with this resident before it started an antibiotic, okay? Another progress note is about when a resident was started on antibiotic, when you do follow-up monitoring, okay, you have to address what's the response of the resident, okay? The resident has now started with antibiotic for respiratory infection, for bronchitis. This is the 3rd day out of 7 days. So I know you're using your templates. Anybody uses the templates in your Sigma for documentation?
Yeah.
Make sure the template guides you what things to write. Don't just mark X thing, putting X marks. Okay, the interventions here says observe, record, report signs and symptoms of adverse reaction. What did you observe? Nothing was. That's your intervention. Monitor effectiveness of medication, encourage fluid intake. And the evaluation says no signs and symptoms of adverse reaction. So what is the response of the resident with the antibiotic? Is he still coughing? Is there still greenish sputum observed? Is there SOBs observed? So those things has to be, and there's no vital sign. Vital signs has to be part of your documentation. Because that's the easiest way to identify if there's a change. Okay, don't just like putting things like putting X marks on your template. Okay, it has to be specific and resident focused. Another documentation, it says that resident's daughter stopped by social worker office to discuss the resident's mental status. Per daughter, the resident received lorazepam and is very sleepy or groggy, but also agitated as she is trying to stay awake. The problem is like, there's no documentation. Why is the resident received lorazepam? Was there a behavior? Okay, and then there's no follow through. This is the only progress note I found in the shift, and there's what's going on after that. Nobody made a follow up on those documentation. So there should be a follow through with those things. It's important for you to read what's written before your shift, what's going with this resident, so that you would tell a story of, okay, on my shift, this is what happened with this resident. Don't just jump from one topic to another and just for the sake of writing things. You have to tell what's going on with this resident. Okay, so this is, and there's no stop and watch. The unit nurse was not informed, nothing. I don't know what's going on with this resident after this shift. Okay, another observation is like the resident reported that, stated, I don't know what happened, I did not fall, I must have hurt my butt on the wheelchair handle. Resident was observed with ecchymosis to the right buttock. And in here, it again, it was signed off by a nurse. I could not determine